Good afternoon, everyone. Welcome to this year's virtual McLean County Behavioral Health Community Forum. If you have been attending other sessions this week, the two we had on Tuesday, you will know that this is our 5th year for the forum and our 2nd year being virtual. We are really happy that you're joining us today, and this event arose out of the 2015 Mental Health Action Plan as a way to help educate the community about not only mental health, but available resources, as well as to help reduce some of the stigma attached to mental health and the discussion surrounding it. We are really happy to be able to pull together a diverse range of sessions each year and have a planning committee that prioritizes what our community in particular would benefit from on a year-to-year basis. A few housekeeping tips for today. You will notice that there are handouts for this webinar as well as all of the other webinars. And one of those documents is a tip list of things you can do to help support your own emotional well-being and those around you. And that's a compilation of ideas from our planning committee as well as some of our presenters and panelists for this year. We have a couple of handouts from PATH about resources, as well as some upcoming mental health first aid trainings. So we encourage you to check those out. All of our forum sessions are recorded and then are available later on the BHCC YouTube page, which can be found through the county's website. But we also try to make sure that we link it in the chat box at the very end. If you have questions throughout, our panelists will take questions at the very end. We find it allows for the flow a little bit better. So you have a questions box that you can enter your question in. I do ask that you are specific with your question since it will not be asked in the moment, so you provide a little bit of context. And if your question is directed to either a person or an entity in particular, feel free to note that. So with that, today's session is on the McLean County crisis continuum and assorted service providers who assist and take care of individuals in our community who are experiencing a behavioral health crisis. Our panel moderator for today is McLean County Board Member Susan Schaefer, and I will turn it over to her to get started and to introduce everybody.
Thank you, Tricia. So I'll start with introductions. First, we have Kevin Richardson from PATH. We have Megan Mosier from the McLean County Center for Human Services, Luke Sawich from Children, Youth, and Family Solutions, Kevin McCall from Triage Center, and Deetra from Chestnut Health Systems. So I want to start off, just want to kind of give everybody a little overview. One way to envision the crisis system is along a continuum from the least restrictive to the most restrictive. And utilizing a no wrong door approach, which McLean County has used as a standard for many years, there are some essential elements from the National Guidelines for Crisis Care. And those are a 24/7 crisis call center, mobile crisis response, and crisis receiving and stabilization facilities. So another way to think of it in a really simplified way is someone to talk to, someone to respond, and somewhere to go. So in the past forums, the crisis panels explained what services their agency provided. And last year's forum was virtual and it was recorded. So you can view the crisis. Crisis has been part of the forum ever since it started, the crisis panel. So you can view that, as Trish had said, on the Behavioral Health YouTube channel. So this year we decided to mix it up a little bit. And we're going to have some scenarios to demystify what actually happens when someone is in crisis. I'll be setting up some situations and then ask the various panelists to respond as to why that was really an appropriate response to that scenario. So we'll be able to illustrate how the no wrong door approach shows how all of our agencies work together too along the continuum for person-centered care. So with that, I'm going to kick off our first scenario. Josh found out the eviction moratorium ended in Illinois, and now his landlord promises him he is going to kick him out, posting a 5-day notice on his door. Josh was already overwhelmed, hopping from job to job, trying to make ends meet. He's a single parent with 2 kids. He often thinks about how his 2 kids are the only thing that keep him going. Lately, he's been thinking more and more about how they would be better off without such a failure of a father. He can hardly put food on the table for them. Now they won't have a home. He doesn't know what to do and feels like ending it all. He Googles suicide, and the first thing listed is the National Suicide Prevention Lifeline, and calls that number. So when you call that number, you're going to end up talking with Path. And so I'm going to turn it over to Kevin, who's going to go through what happens then.
All right. So one, thank you for having us and having Path's representation. We always appreciate doing this. And so, yeah, if you dial the National Suicide Prevention Lifeline, if you dial our own crisis line, if you dial 211, you're going to reach Path's 24/7 call center. And when you reach us, you will be speaking with someone who has gone through a very thorough training on how to handle whether it's just someone who's in need of rent assistance or someone who's at this point, feeling suicidal. And then what are we going to do? And so we've gone through a thorough training. We operate with volunteers and staff. And so what we end up doing is, first and foremost, we're going to validate what that person is going through, what we call reflecting with them. And so letting them know, hey, you did the right thing by calling. I know right now it's overwhelming. We're going to do what we can with you and work with you and see what's out there that might be able to help. And a lot of that it's before you jump into problem solving. I mean, let's say he's crying on the phone, right? Me saying, hey, well, you should call Prairie State Legal Services about that eviction while this guy's crying on the phone. That's not going to be helpful. It comes down to, you want to validate what they're going through, really show that you're there and you're listening. And that's exactly what we do. Everyone that we train on the call center, they're here because they want to be. Most of it is volunteer based. And so we're wanting to help people. We want to listen. We want to make sure that they're doing okay. Now, because he has mentioned suicide, we have to ask some very direct questions. In this case, he's mentioned, maybe not directly, but he's hinted that he's overwhelmed. He can't take it anymore, right? So that prompts me to ask something like, or say something like, sometimes when people are feeling like at their last wit's end, they're thinking about suicide. Are you thinking about suicide right now? And so you ask that very directly. So then we're on the same page. Okay, are we just talking about someone who's overwhelmed and not thinking about suicide at all? Or are we talking with someone who's very overwhelmed and thinking about suicide? And that kind of makes it so we know, okay, which way are we going to take this? This person, maybe they just need support, but now they need like a safety plan is what we call it. And so we'll assess more, we'll ask some more questions related to that. Actually, because we are part of the National Suicide Prevention Lifeline answering centers, we have to ask certain things. Outside of that, you're having a conversation with us. We're not trying to get you to the hospital. We're not trying to get someone to pick you up or anything like that. When we talk about demystifying, I think I want to emphasize, I mean, all of us are aiming for the least restrictive policies possible. Anyone who's done any research on any of this tells you that's how you see the best results. That's how you see actual improvement of what's going on. And so we are going to gauge that level of suicidality. And we do that through asking some questions. We do that through analyzing what you've already done. I mean, do you have a therapist that you talk to currently and they're just not available right now? Do you have a friend that you talk to regularly about this and they're just not available right now? We're going to gauge all of that support, what we call buffers in that person's life. And then at that point, after the situation has maybe calmed down a bit, that's when we're going to step more into the problem solving. And so, he mentioned that the first thing that really seemed to put him over the edge was the eviction moratorium is over. And that's going to affect a lot of people across not just McLean County right now, but the entire state. That just ended a couple days ago. And so call 211, call Path Crisis Center. We are going to do what we can to help, and sometimes that is just listen. Like sometimes people need to talk, but in this situation in particular, we're going to gauge that safety. And I forgot to mention, make sure that there's no immediate danger, right? So that, that's the first thing that we're going to do. Do you have anything there that you can hurt yourself with right now? I just want to make sure that you're safe on the phone while we're talking. And assuming the answer is no, then we just continue the conversation, and so at that point, there's several referrals. So we've got lots of different things. The way that our database works is we have a database of over 3,000 agencies that offer different services. Now we cover more than just McLean County, so only hundreds of those are in McLean County. But we're going to offer rent assistance, for example. Are there programs out there like through the Bloomington Township or through Mid-Central Community Action? And there's a few more based on the situation. At that point, I would also offer, like I alluded to earlier, legal assistance. So Prairie State Legal Assistance, they're offering help with people who, because we anticipate literally thousands of people are going to be facing eviction potentially if their landlord isn't willing to work with them, or if the landlord's hands are tied. It's not necessarily their fault either. So we would offer that. And so they have specialists who would help with that. We would offer, in this case, food pantries as well. Worst case scenario, we're going to talk about the shelters in the area. We're going to talk about any resource that might be brought up, and we're going to check with them too. It's not us telling you what to do. It's asking, how can we best help you? Like, what do you feel like you need first, right? And so we're trying to work with them in that sense. And so in this case, to me, it's some of those basic referrals like legal aid, food, rent assistance, potentially shelter. And then we're going to set up a follow-up with this individual too, after we do a safety plan, because they are thinking about suicide at this point. And so there's no intervention needed in this case. Now, if things start to escalate over the phone, that might be when we reach out over to Megan's crisis team over at Center for Human Services and get a little more expertise in there, and potentially, someone can visit and she's going to talk all about that. But it depends on how that call goes. Based on what we're seeing here, I would gauge that as this is just someone who's at their wit's end. They needed someone to talk to, one, and they needed some resources. And that's exactly what we're here for. And then we can connect you with other people if you feel like that's necessary as well.
Great, thanks, Kevin. So on the follow-up, like, is it like the next day, or is it, a week later, or how many times do you follow up on something like this, since it was just a call? So, they just had somebody to talk to. What kind of follow-up do you do, and how often, and that kind of thing?
Yeah, that's a great question. So in this case, because there was some suicidality expressed, while I would say it's pretty low, it's just they're at their wit's end and they don't know what else to do, as opposed to they have a plan and they're going to do it now. There's still some suicidality expressed, and so we're going to follow up within 48 hours. Generally, it's like the next day, about the same time next day. Now, if this was someone who wasn't feeling suicidal, they're just dealing with all of this mess and they are at their wit's end, but there's no way, I'm not thinking about suicide. We want to check in, but it's not as urgent that we check in within 48 hours. So it might be 3 days from now, 5 days from now, a week. We work with you. I mean, we're just going to ask you what's the best day and time to call you. Is it Saturday at 5 a.m.? Great, we're 24/7. We can do that. Is it, a Thursday at 12 p.m. when you're on lunch? We can do that as well. So we'll set that up in our system and make sure that someone's reaching out at that time.
And I have one more question, because it really does apply to everybody on the panel, about the confidentiality. Are you going to ask them their name, address, all this kind of stuff? And then what are you going to do with that information?
Yeah, I appreciate you asking that as well, because I think sometimes there's like horror stories out there. Like, I called the National Suicide Prevention Lifeline and then police just showed up at my door. Frankly, if this situation was going on and that's what happened, that center, that person taking that call did that completely incorrectly. And I apologize that there are situations nationwide where you hear about stuff like that, because that's not how this should go. It's completely confidential. It's completely anonymous. We ask for your name at the end of the call, unless we've asked for it during the call, just to be a little more personable. To like, who am I calling to follow up? You know, how can I get your name? And that's when we get your phone number and things like that. Now, if I'm looking for resources for you specifically, based on which phone number you call PATH, like if you call 211, it initially asks for your zip code and you enter that in. So then we have an idea, and then we're going to verify it with you. So then we have an idea of which resources we can offer you. Because, you know, Mid Central Community Action in Bloomington Township, they can only help within, one, Bloomington, and two, McLean County, offering you services. We get calls all the way up in Winnebago County, Rockford, all the way down to Southern Illinois, Carbondale, that sort of area. And so if I'm giving you a resource that's based in Springfield, but you're living here in Bloomington, that's not going to be helpful. So bare minimum, we're going to ask for your zip code. And that's it. Now, I do want to note, and we'll get into this probably as this is going on, if someone has called and they have already taken the pills, if they have already taken action to end their lives, they've already cut their wrists, they're worried that they are bleeding out, you know, something very extreme, what we call an in progress situation, we are, very honestly, we're going to do everything that we can to locate you, because that's what the National Suicide Prevention Lifeline does. So, and oftentimes when people are calling in that state, it's because they feel like, hey, I need help. So that's exactly what we're going to try to do at that point. Outside of that, again, least restrictive policy possible, and everything's confidential, everything's anonymous. And, you know, you can give us a fake name. I mean, we wouldn't know any better, right? So it's very, we take that very seriously.
Great, thanks. So for our next scenario, we have a family is concerned about their mother, Kelly, who they have been checking in on regularly, but lately has been struggling more with her daily activities and mood. She appears more down and makes comments here and there about feeling like a burden and she has no purpose or direction. I think we all feel like that right about now with COVID. She previously had supports within her community, her church, and friends. However, these supports have been more limited than last year. She made a statement about not wanting to be here anymore, and the family is unsure what she meant. You are concerned about Kelly, and you feel that talking to someone about these changes would benefit her. When you discuss options with Kelly, she's open to the idea, but would feel more comfortable talking with somebody in her home. You called 211, and PATH does a warm handoff to mobile crisis because they obviously wanted to be in their own home. So Megan, I'll have you talk about this one.
Sure. So oftentimes I think people don't realize that PATH does answer for us after hours. So some people can call us through our office, but if it's at nights and on the weekends, PATH will answer for us. Or people can call 211 and then out of the different resources, if the volunteer, like Kevin said, kind of figures out what's going on and then realizes somebody would kind of like maybe someone to come out to their home to talk to somebody more, that's where they would then hand off to us. And so how that works is they will, we actually go off a pager system. So they page us and we talk to the volunteer and get a little bit of information. That way the person doesn't have to reiterate themselves or have to tell their story over again for what they already told to the PATH volunteer, which is really, really helpful. That's kind of that nice warm handoff to where I know maybe their name, I know a little bit of the situation, I know they're worried about their mom. So I'm able to, when I first call, you know, I would say, hey, you know, I'm calling from the mobile crisis team and I heard that you talked to PATH, sounds like this is what's going on, could you tell me a little bit more about that? So that way I'm at least trying to condense what I know already so you don't have to repeat yourself, but then get a better understanding of what they're really looking for at that point in time. And so we, a little bit different than PATH, because we would want to go to somebody's home, we do need to get a little bit more information. So we would need a person's name, their address and things so that we could meet them in their homes. But as a mobile crisis team, we can meet with people anywhere within McLean County. So as long as a person physically is in McLean County, then we can actually go out to somebody's home and talk with them more about things. So it sounds like, for this individual, coordinated with the family, answering some questions, and then oftentimes we will even try to meet with them. We'll see what they feel is most comfortable for that person. So kind of going with what Kevin said with least restrictive, we want to do something that makes somebody comfortable. And so we would go out to the home, and sometimes once we get there, the family we usually leave it up to the person that they're concerned about. We introduce who we are and why we're there, and we kind of talk about the fact that their family member was concerned, and then just like Kevin said, there's a lot of similarities between some of the things we do. A lot of it is a conversation. We're not going to come over and just sit there and pepper you with a bunch of questions, one after another. We are trying to assess what's going on and trying to see some more clarification on some of the statements made, some of the things that were said, feeling like a burden, feeling like a lack of purpose. I think that's a lot of times we've had this increased stress, since COVID, and there is a lot of stuff going on, but sometimes feeling like a burden can mean that you feel like ending your life, and sometimes it could mean you just feel a lot of things right now, and you feel like because of some of the stuff going on, you are more of a burden, but it's not necessarily that you would want to end your life. So we really try to make it into a conversation that we're having with somebody, and just trying to figure out where they're coming from. Very similarly to PATH, just in person instead of over the phone. And then oftentimes, we're just trying to, again, look at safety. Like Kevin said, we would want to clarify some of the statements made, because those would be a little bit more concerning. If you're more down lately, if you're feeling like not being here anymore, that can mean a lot of different things as well. So we want to kind of get some clarification on that. And then, oftentimes it's trying to then, once we get a better handle of the situation that's going on, then we like to provide that support, that kind of brief counseling, validating, like Kevin said, is a lot of showing that there's people out there that want to listen, that are there to try to help and be supportive. And then the last part that we do, like in this scenario, once we clarified whether or not those statements were for suicide or if it was just feeling overwhelmed, a lot of times people feel more and more overwhelmed due to not knowing what's available. COVID really did switch so many things, like in this scenario, you may have gone to church in person and had a community around you, and now it's virtual and you've had that for a while, or you had different people that you were meeting with and maybe they're no longer doing those same type of things, and so it's really changed how isolated we are at times. And so sometimes it's showing what the current resources are or the current supports are that can really help somebody feel less isolated. And so then we provide some of those resources to someone. And then, like Kevin said, we also do safety planning. And when we do that, we try to talk about, not just for suicide, but just for in general, what makes you feel worse, and what are some things that you can do when you start to feel that way to feel a little bit better? Is there some coping techniques that you can use? We have a lot of different resources for ideas of what can help when you're struggling. And so we like to give people that. I find that tangibly having something that you can give is really, really helpful at times. And then we also, for anyone that we see, provide follow-up as well. So besides just going over things and providing maybe a safety plan and resources, within 24 hours we'll call and we'll just ask how it went. How are you doing now? Are you feeling any better today? Are you not feeling better today? And kind of offering just that extra added kind of check and follow up, so that that we're still there. We want to make sure that things were either better, or if they aren't better, then try to provide that support again and figure out if there's a different level of care that might be needed because things aren't getting better. But like Kevin said as well, our goal is very much to try to keep people in least restrictive. So I think he did a good job saying sometimes people feel that someone's just going to try to get them to go to the hospital, or just trying to do different things, but really the goal for our team is always to try not to do that and to do whatever we can to do that safety planning in the community. We really like meeting with people in the community where they're more comfortable, usually where you're more comfortable or you're more willing to share more things. And I think it's just a much better way to get to talk to somebody in that moment. So that's a pretty good overview of what we would do.
So when you have something like that, how long do you usually spend with someone? I mean, because
Good
I
question.
could talk to somebody for a long time, or a short time, kind of thing.
So as counselors, we want to give everybody time that they need. Usually it just depends on how open that person wants to be. Sometimes it's 15 minutes of talking to somebody, providing some resources, up to half an hour. Sometimes we've spent an hour or so with somebody just kind of talking. It depends, like Kevin said, if somebody's crying, really upset, or feeling really overwhelmed, sometimes it takes a little while for them to tell us everything that's going on so that we can give them the appropriate resources. So usually anywhere between half an hour to an hour is where we spend, but if it was appropriate and that person needed a little bit longer, sometimes it's a little bit longer than that. But usually people can get most of what they're wanting to talk about and be able to provide those resources in about that amount of time.
In this case, there was family there. Do you usually include the family, or do you, just let the person be by themselves, or, because sometimes people will say things, without family there, and they would say different things or not say some things with family there, or friends or whatever,
Another good question. Yeah. So we leave it up to the person. We usually say, what do they feel comfortable with? If they're like, you know what, I don't want my family here, I don't want them to hear different things, then we would offer some options. Either the family might take a step out, and then we can talk to them by themselves. Sometimes people want their family there. They feel a lot more comfortable with somebody else being there to kind of provide that support. And sometimes your family is your biggest support, so they're kind of the ones there. But we always try to offer that individual time too, because sometimes, like you said, somebody's going to maybe say something different or want to be a little bit more open when their family isn't around. So we like to make space for both of those options. So we really want to make it what's the most comfortable for the person that we're seeing.
And I have one more question. Do you go out by yourself, or are there more than one of you, or 2 or 3 of you, or how does that work?
Sure. So right now we do go out individually, but we are incorporating to go out in pairs where we have kind of a crisis counselor and then a peer, so someone with lived experience that's been through different situations, to go out together. So right now we kind of have a mixture depending on availability of people, but so it could be an individual person, sometimes it could be a pair.
Great, thanks. So we have our next scenario. There's a lot of focus on youth and how youth are faring these days. So this scenario is Leon, who goes by the name of Emily, is a 15-year-old transgender teen identifying as female, using pronouns she and her. She has a history of suicidal ideation and frequently posts her suicidal thoughts on social media. Emily reports that her therapist has a lot of drama amongst her friends and peers at school, and often claims she is being bullied for being a trans girl. Emily's grades in school have been in sharp decline from her usual A/B grades prior to COVID homeschooling last year and returning to in-person this year. Tonight, after a fight with her mom about grades, she sent a goodbye letter to school friends and her favorite teacher at school via email. Emily broke into the lockbox where her medication is stored from the previous safety plan and quickly swallowed all of her antidepressant medication. She did not tell her mom she did this until she started feeling weird and got scared. Emily's mom called the paramedics, and she was quickly transported to the local emergency department. After medical staff contacted poison control, monitored her vitals, and medically cleared her, they called CARES for a SAS evaluation. So Lucas from CYFS, I think this one's for you.
All right. So again, thanks for having SAS on the panel. So basically, the reason SAS was probably called is because of their insurance. The difference between crisis, mobile crisis, and SAS is determined by the type of insurance the youth has. So my guess is that the insurance is a Medicaid-based form. So basically what would happen is we would get paged. We're on the same kind of a pager system as mobile crisis. We would get paged by CARES. We would get basic information of what's going on and presenting that she has overdosed. She's medically cleared by hospital staff, where she's currently located, and we would go to that location. At that point, we would talk to her about how she's feeling, kind of the presenting issues of why she felt that was the route she chose to take, kind of get a little background information from her, and then build off of her strengths, especially with teens right now, and anybody really, but teens especially are really feeling the pressure of COVID restrictions and their socialization. So really building off of those strengths that she has, if she can identify any, and using those to safety plan. In this case, because she had a significant overdose, chances are we would probably have to hospitalize, only because of the safety risk there. There was already a safety plan in place. She was able to break into a safety or into the lockbox, which was already safety planned previously. So there's a significant risk there that we would have to go hospitalization. And again, like going least restrictive, hospitalizations are very traumatic in most cases. So we generally try to shy away from hospitalizations because of that. But when we have a significant safety risk, we have to look at hospitalization as an option. So we'd probably go that route with her. And then at that point, we would contact the parents. Hopefully parents are there, and talk to them about, what they're seeing, how we can move forward once she returns home from the hospital. And then we would set up 90 days of follow-up services, which I think is the difference between Megan's program, correct? Yeah. We do 90 days of follow-up therapy services following the crisis intervention. And yeah, so that's pretty much what we do.
So when you're talking about hospitalizations, and you said it's pretty traumatic, and I know that we don't have anything here, so how does that work when a child has to be hospitalized, and how do you try and place them based on the fact that we don't have any place here for them?
Sure. So that's a really good question. And I think that's something that a lot of parents get overwhelmed with when we hear that we have to place outside of the city. We have 3 local closer hospitals. We have a hospital in Peoria we can use, a hospital in Champaign we can use, and a hospital in Springfield. Those are the 3 closest that will take adolescents and youth. Outside of that, then we're looking at hospitals further away, such as like Joliet, and then into the Chicago suburbs. So that's part of the trauma, right? Because we're taking that child away from their home environment. That can be a very scary situation. So we try really hard, again, with the least restrictive intervention. So we try to be as close to home as possible, because we don't want to put on an additional burden on the family either, trying to arrange transportation to pick them up from the hospital when they're discharged. Hospitalization, if they're in a hospital situation, we can do everything within the ED in the emergency department. So we make all the phone calls, we call hospitals, we give the presenting information to the hospital about what the situation is. And then from there, we wait for the hospital to make a determination if they can accept that individual or not. If they decline or they deflect, then we go on to the next closest hospital. And then we continue that process until we find appropriate placement. And then once that happens, then we arrange transportation, and that individual is transported to the hospital for psychiatric care. And then after that, then we get notified upon discharge to begin follow-up services through SAS. So once that happens, from the point of discharge till the time SAS follow-up services begin, there's about 24, 48 hours after discharge. before we make contact with the family and arrange follow-up services.
So you, in the scenario, they had a safety plan, so the safety plan obviously wasn't working. So then do you create a new safety plan and work that way?
Yes. So every crisis is different, right? Regardless if it's the same person or not. So we always take a fresh look at every new crisis. So if there's a safety plan in place, we can take a look at that and say, okay, what parts of the safety plan worked and what parts didn't? And then we figure out a new safety plan based on, you know, the things that worked and then the things that didn't. So if obviously the lockbox wasn't working, we may encourage to get a better lockbox or find a new location for the lockbox, you know, where those medications are harder to reach. You know, hopefully once we get psychiatric care back and that suicidal ideation is declined, you know, those needs for more restrictive safety plans aren't as necessary. If they still are, then, you know, we definitely work with the family to make sure that those are able to be met.
So since the child was in school, do you share those safety plans or any of this information with the schools or their counselors at school so that they can help maybe prevent or notice when someone is getting closer to going back into a crisis situation again?
Sure, it would depend on the youth, what she would want, right? So like if she feels that she wants this shared with school, then yeah, we would. If the parents feel like the school needs to be involved, then absolutely. But really where we're at with that is we want to meet the individual in their comfort zone. If they don't want a ton of people involved because it's a scary thing, then we really try to keep them in their comfort zone while keeping them as safe as possible.
Great, thank you.
Mm-hmm.
Moving on, our next scenario is the Bloomington Police Department were called out to South Bloomington with reports of a middle-aged white male walking up and down the road, tearfully talking to himself, clearly in a state of extreme distress. Officers responded to the scene and determined the man's name was Craig. Craig stated that he had recently lost his job due to COVID and is afraid that he might do something stupid. Craig is clearly intoxicated, but was still oriented with reality and capable of communicating clearly with the law enforcement officers. The officers determined that there was no immediate medical concern and that Craig was not a threat to himself or others. Craig asked for a safe place to talk to someone and stated he did not want to go back home because he was embarrassed to be seen by his family members. Law enforcement suggested the McLean County Triage Center and assisted in transportation. So this would be Kevin McCall, who says he's at McLean County Behavioral Health. Kevin.
Yeah, so for this example specifically, there are some specific things mentioned in there to kind of show why triage would be the appropriate resource instead of, say, mobile crisis. In this situation, there's a little bit of subjectivity on behalf of the officers to determine what's most appropriate for the individual. So let's say Craig wanted to go back to his home. There's a good chance that mobile crisis would be called instead, and they would go out to the house and they would perform the assessment there. Maybe he wanted the support of his family members, but in this particular circumstance, he was just embarrassed by his current state and so did not want to go back there. The officers also have the opportunity to take someone to the emergency department. And in many ways, the triage center serves as a deferment point from the ED so that we don't become overwhelmed and services are being used most appropriately. There were a couple of other things that were highlighted there too, as far as how intoxicated he was, how capable he was with communicating. Now, currently with law enforcement in this community, and that includes Bloomington Police Department, Normal Police, and the McLean County Sheriff's Department, we do provide them with a card that looks somewhat like this that highlights a couple of items, and I'll read them to you. to kind of determine, is someone appropriate for the triage center? So those things are, does the individual appear to be safe from harm to themselves or others? Oftentimes, that is something that we end up determining when they're actually brought into the triage center. Is the individual sober? Obviously, there is a level of kind of subjectivity there. Again, a person does not need to be completely sober. They need to be capable of communication, and it needs to be a non-medical emergency. Is the individual suffering from some type of crisis? Does the individual have a history without violence? And does the individual have a known or suspected mental health diagnosis? If it is yes to all of those things, then triage is definitely a place where that individual can be deferred to. We are trying to give some more concrete items. Working with the NYU Criminal Justice Lab, we are working to roll out a tool to eliminate some of that subjectivity with law enforcement officers, to allow them to make an objective decision for certain deferment points, with the McLean County Triage Center being one of them. The McLean County Triage Center itself is located at 200 West Front Street, which is the same building that houses the health department in downtown Bloomington. We're open 7 days a week, 365 days a year, and our current hours are from 7:30 a.m. to 3:30 a.m. The Triage Center serves anyone within McLean County that is over the age of 18. So you do not necessarily have to be a McLean County resident. There are plenty of times where we have had someone from out of state who's experiencing a crisis, who just kind of stumbled across the Triage Center, and we were able to connect them to community services here to help them with their particular situation. When you enter the Triage Center, there's basically 3 different roles that we have here. The first person that you're going to see when you come in, and in this case, we'll say law enforcement is dropping off Craig, our visitor's aide and our peer support specialist will have a brief conversation with law enforcement in order to have somewhat of a warm handoff and understand, what was the situation, what's going on. Typically, what we're trying to do is to unburden law enforcement officers. So we want to keep them there as short as possible. We have a form that we have them fill out that takes down their badge number and just kind of a brief synopsis of what the situation is. And on average, I would say law enforcement spend no longer than 5 minutes in the triage center. So our visitor's aide would then, we go through kind of a security protocol. We use a hand wand to make sure that, everyone's safe. There's not any dangerous weapons or substances being brought into the facility. And our visitors' aides are plainly dressed. They do not look like the McLean County security that we have here on other parts of the campus. It's to be as non-threatening as possible. And they are also cross-trained in behavioral health, so that they have more of a compassionate and understanding response to people in crisis. Once they kind of get past that stage, we do have a series of intake forms that need to be filled out. And we utilize, and Megan kind of alluded to this role, peer support specialists. And that's someone that has lived experience with either behavioral health or substance abuse issues. And they, again, are able to kind of provide that compassionate response, because one of the hardest parts of being a physical location is that we do have to get signatures for certain liability reasons. And when someone is having potentially the worst day of their life, it's really hard to expect them to focus in on all of that paperwork and sign their name and fill out all of that sort of demographic information. So the peer support specialist is there to help them fill those things out and kind of get that preliminary report of, what brought that individual in today. Once that's done, that information is then passed on to our specialist, who will then determine if a further assessment is necessary. And we do an assessment that is very similar to what Mobile Crisis does. That is very intentional so that there is a little bit more continuity across the community. We're of course assessing for suicidality and homicidality, to determine, kind of what the next steps are. We will petition people if we feel that it is necessary. That doesn't frequently happen here at the Triage Center, but we have had to do it a few times. One of the things that's unique about the Triage Center is that we follow a living room model. So in the case of Craig, where maybe he just needs some time to kind of decompress, get rid of some of that anxious energy, sober up before he's ready to talk, individuals can stay in our living room, which has a couch and chairs, different coloring books and knickknacks and things to do to just kind of take your mind off of the present crisis and you can stay up to 23 hours. And so just to be clear, I stated our hours are currently 7:30 to 3:30 a.m. If anyone ever needs to stay for 23 hours, our staff will stay throughout that time. And so if we determine an assessment is necessary, we go through that entire assessment with them, and then we also incorporate safety planning in the same way that Mobile Crisis would, or any of the other organizations here today. Really, at that point, we're just trying to connect them to, whatever community resource best fits their needs. So in Craig's circumstance, he is probably mostly concerned about employment. That's something that's near and dear to my heart because I've worked at the ISU, Career Center before, so I know all about job searching and things like that. So I may be able to use some of my own personal skill set to help give him some confidence in here's what other types of jobs are available, let them know what the landscape is during COVID, and have those discussions to kind of de-escalate the situation. As far as any other resources in the community, I have to give a big shout out to PATH here. They've recently updated their website, and it is an incredible resource to see what is available out there, and you can even search by zip code. So if I know where Craig lives, I know what kind of resources he's looking for, I can go to that website in addition to the knowledge and things that we have here and determine what a best fit is for Craig. And so we will incorporate that all into the safety plan. Once we determine, that the individual is not suicidal or, a harm to themselves or others, then they are usually discharged from here. And typically individuals here are discharged to home. We will also set up people with, shelters or various other services. But it really just depends. Every situation that comes through our door is completely different. We do walk-in services only, and that is very purposeful so that we do not duplicate other community services. Triage does not have a public phone number because 211 is the number that you would call if you were in a crisis and you needed to talk to someone over the phone. We do not go out into the community because Mobile Crisis performs those assessments out in the community. So really, we're just there to try and fill that existing gap and to help places like Mobile Crisis that we know are having, tons of calls, and really sometimes it's difficult to keep up with the demand that's out there. And I think similarly for PATH. So yeah, it really just depends on the individual situation, but we're really, our biggest goal is to make sure that we're connecting people to the most appropriate resources and that they leave triage better than when they came in.
Thanks, Kevin. I do want to make a comment here that almost all of the officers throughout McLean County, Bloomington Normal, and the Sheriff's Office and ISU Police have had crisis intervention training. That's happened a few years ago. We received a grant from the Bureau of Justice Administration, I think is the name of it, and managed to get all of the officers at that time trained in CIT so that they can de-escalate if they can out in the field. And that's probably what they try to do with Craig and see where he was at. So thank you, Kevin.
Thank you.
Our next scenario is Jordan feels anxious to the point of being unable to make decisions and feeling so overwhelmed with anxiety, he feels unable to breathe and has ringing in his ears. He has been given an anti-anxiety medication from his primary care doctor, but he finds he has to take it much more often than he used to. Recently, he has noticed that his anxiety is especially unbearable during his regional sales meetings on Zoom, and he has had to log off calls. He is unable to take care of his day-to-day responsibilities around the house, and his partner is very worried about him. Deetra.
Hi, thank you on behalf of Chestnut Health Systems for including us in this conversation. I'm going to start a little different than the rest of the group and say that really any of the prior speakers' venues would have been appropriate for this particular scenario. But I was asked to speak about what our program, did. And so in this particular case, what most likely happened is that the family was maybe not familiar with some of the ambulatory resources previously described, and they called directly to Chestnut seeking services. And So Chestnut does offer a crisis residential unit. It is a combined unit with our medically monitored detox. And really, the goal in that unit is least restrictive environment. So we offer a multidisciplinary team approach. Persons with mental health issues and or substance use issues can access our services. And so in this case, Jordan would most likely call to indicate that he's seeking some services, would be screened by someone in our call center for placement along our continuum of care, and if appropriate, identified for the crisis residential unit, would be given a time to come to our Martin Luther King building, which is at 1001, for an admission. And admissions are based on, bed capacity. And so when Jordan arrives at Chestnut, Jordan would be greeted by someone in our reception area. There would be, just like the Triage Center, some paperwork, requisite paperwork that we have to go through. And then Jordan would be then, upon completion of paperwork, greeted by one of our multidisciplinary team members, most likely one of our medical assistants, and taken back to a area where Jordan would be screened to make sure that Jordan is medically safe and cleared to be in a 24-hour residential type setting. And at that point, then we would do a physical exam as well as a clinical exam. And so when I say multidisciplinary team, we have peers. So we've talked about peers now in 3 of the other presentations. We do have persons with lived experience participating in our program. We also have case managers, counselors, nurses, and then additional medical support. So initially, if I were to back up, the first thing we would do is make sure that Jordan is explained what services we offer often, and that we're addressing the initial mental health issue that Jordan's describing. So once cleared medically to be on the unit, we are the difference I think between Triage and Chestnut, the easiest differential is that this is a 24/7. A typical length of stay is anywhere between 4 and 5 days versus a 23-hour. And so there are level of care criteria, that we look at that kind of, excuse me, helps us determine whether or not triage would be appropriate versus the residential program. And so while participating in our program, our goal, similar to the rest of the goals, is really least restrictive environment. So our goal is to help the client reconnect with whatever resources they may have currently in place. And so in this case, we know that the client has medication prescribed by a primary care physician, but the medication may need tweaking. So we would reconnect with that client with the appropriate releases, reconnect with that client's primary care provider, identify what's going on, and see if the primary care provider is interested in tweaking the medication or potentially changing medication. If the client does not have a prescriber on record, then we would help potentially connect the client with a prescriber if a medication assist is appropriate. And so least restrictive would be some of the questions that we may have for the client is, are you under the care of any behavioral health clinician or any, are you working with any other organization in the community, and how can we help you connect with your organization? So the goal is, again, to reconnect with whatever support systems are currently in place, provide the client with a safe environment, and sometimes the client just needs that opportunity to meet in either individual sessions or group sessions to process through their feelings, and they need that they need that opportunity for reflection, and like I said, length of stay is averaging 4 to 5 days. I don't know what else you're looking for, Susan. I mean, it is an inpatient program. It is, this particular unit is dual gender. So we have, it is a unit that has all genders on the same unit, although they don't share same room. So room assignments are gender specific, and room assignments are specific to the reason for access. And so we would not typically combine someone who's accessing for mental health issues with someone who's being medically detoxed from a substance. We do have curriculums in place, and so the clients have opportunities to participate, like I said, in individual or group work, and then meet with case managers to reconnect with or connect with in the case that they don't have those resources in place. We are not a locked facility, so when we talk about our continuum of care within the community, we're less restrictive than a hospital-based setting, and so clients have the right or the opportunity at any time to leave the facility, and different from other medical conditions, and something that I think many concerned family members find confusing is that when we take a loved one to the hospital or an inpatient program for a medical condition, oftentimes we camp out at the hospital and we want to be as close to our person who is dealing with a medical condition as possible. In our particular environment, especially given COVID, it is not the case that the family is back on the unit. You know, some of that is to protect the privacy of the other clients participating on the unit. And so this is one environment sometimes where we see concerned family members who come with their family, frustrated that they're not more involved, or that they can't go back and see the room, or that they can't stay in the room with their person and get them settled in. And so that's where our peer and our peer support and some of the other staff really a big piece is in a group environment, introducing the new client to the routine of the unit, the other clients on the unit, and then I know when you said the Triage Center had coloring books, I found it interesting because that is our #1 recreational activity. I think it's keeping our hands busy. So we do a lot of rock painting and coloring initially, just to get past that initial maybe anxiety of just being in a new place. So I'll stop there, Susan, and see if I missed something that you have a question related to.
I have a couple questions. Can you say what your location is again?
1001 Martin Luther King Drive. So we are on the west side of Bloomington off of Market Street.
Okay. And so after someone has been in the CRU for 3 or 4 days and they're ready to leave, what kind of follow-up then is done with that person?
So in any inpatient setting, the goal at time of, as soon as you're admitting, you're also starting your discharge planning and looking at what are the opportunities for the client post-discharge. And so our goal is to reconnect the client with whatever resources they may already have in place, or to connect them with new resources. And so if they are already under the care of another agency, our focus is to reconnect them with that agency, and then we hand off, we do a warm handoff to the extent that we can. Of course, consent or so your client, if the client says, no, I'm not interested in going back to that agency, then you look for the next. And so at some point during that transition to care, the next level of care really does kick in, is related to care coordination, treatment planning, short-term, long-term goals kind of thing. And so post-discharge, our care right now is the post-discharge planning and the ability for the client to work with the case manager to connect with those, community resources.
Great, thank you. I think we have time for one more, maybe two if we talk fast. George has been living a tough time adjusting to changes over the last year and a half. He lost his job due to COVID, and ever since he's struggled getting back into his normal routines. One night, he admitted to his friend that he feels like ending his life and has access to a gun. He feels scared that he will follow through on these thoughts. He expressed feeling overwhelmed and at his wit's end. George is picked up by, I wrote that twice, picked up by his friend and goes to the emergency department, where he admits to the staff that he almost ended his life. Medical staff order a psychiatric evaluation to be completed and to maintain his safety. George is evaluated by a mental health professional, and it is decided that an inpatient stay is needed. How does this process work, and what is it like for individuals staying on an inpatient unit? I'm going to go back to Megan on this one because I know Megan has some experience working with many of these people.
Okay, yeah, so just like we've kind of been going with the continuum of care, going into the more and more restrictive settings. So when you go to the emergency department, especially for more of a safety issue, so in like this scenario, a person is having those suicidal thoughts, has a plan, and really feels that they would follow through with that plan. So you would go into the emergency department. Sometimes people don't realize you do have to be medically cleared. Lucas kind of talked about that a little bit with SAS with his example too. So when you go in, you do have to wait a little bit of time because they want to make sure medically that you're, okay, and they'll run some lab work and things like that, just to make sure that there isn't sometimes maybe a medical reason why you might feel a certain way. Sometimes people don't realize, some side effects to even medical medications are suicidal thoughts or an increased depression. So it could be maybe there's a level, that's off. So we would want a doctor to take a look, and kind of like what Deetra said, even on their unit, you really just want to make sure medically. Because I can tell you, my staff, while we can definitely talk to you with mental health issues, we don't know any of those medical issues. That's not our expertise. So we really want the person to, be checked out by them. So sometimes that can take up to an hour. Sometimes it takes longer. It depends on those tests that come back. And sometimes people maybe have like an elevated blood pressure or different things where they need to be kind of watched for a little while. Or if it's a case of maybe an overdose or things, you do have to get clearance from poison control, and sometimes they like for somebody to be monitored up to like 6 hours or more. So it can really vary based on how long you might wait to talk to somebody, but you are in that safe setting of an emergency department with people there that you can stay there until somebody comes in to talk to you. So like in this example, our team actually not only goes out in the community and provides assessments in the community, but we also provide the same type of an assessment in the hospital setting. So our preference would be that we could do that assessment if safety is not as much of a concern out in the community, but if safety is a concern, we prefer the person to be safe, and then we'll come talk to you. So similar to what I said before, we try to figure out what's going on, and in this case, we would probably recommend an inpatient stay. And so how that works is we do have one inpatient mental health unit here in the Bloomington Normal area, McLean County, at Carl Broman. So depending on the location of where that person's at, I know we have 2 emergency departments. So depending on if it's at OSF or Carl Broman, we tend to try to stick with the closest location. That's best for families to be able to visit. It's best in general. That's why it is unfortunate we don't have an adolescent unit. I agree with Lucas. It can be so tough, which is why we do definitely start as close as possible because that's in everyone's best interest. So for us, we would start here at our mental health unit here. And then if for whatever reason that mental health unit is full or that person might not be appropriate for that level or appropriate for that that unit, then what we would do is work our way out. So we start closest and work out further. There's many different hospitals in the state of Illinois. So we, like Lucas said, start with Springfield, Champaign, and Peoria as well, something less than an hour if possible. And then if that doesn't work, then we move our way, out further and further. There are a lot of hospitals in Chicago, so that does tend to be an area where we are able to send someone, but we don't want to try to do that if we don't have to, just because we know it's further away. But so that's kind of in that process. It just depends on timing for how long that would take. Sometimes hospitals make decisions quickly. Sometimes they have to look over some different things, and that could take sometimes hours. So in this process, one thing that we do if they tend to have family that are there is we try to educate on kind of the process of it and provide some information, so that way the family kind of knows what's going on, if appropriate for that person. And we tell the person, if they've never been on an inpatient unit before, that can be very traumatic. Where am I going to go? What's going on? And so we try to explain this is what it looks like. Here's what is done on a unit. And so, for example, here in our area, our staff have actually toured the mental health unit here, and we're able to explain a little bit better to people what it's like, different groups that are there, what it's like in the rooms, that you'll have possibly 2 people in a room or not. And then we explain some of the different types of groups, the different types of activities that you can do, and different things like that. So that way it's a little bit more known. Sometimes the unknown makes it a lot worse. So if we can try to help with that education, we do. So when you're on the unit, it's very similar to what Deetra had said, actually. The only difference, the biggest difference, would be you cannot necessarily just leave that unit like you could at the crisis residential unit. So even if you were to go to an inpatient unit voluntarily, like you want to go, you still cannot necessarily just get there and then decide you don't want to be there anymore. You do need to stay to be evaluated by a psychiatrist that's there, and those stays can be anywhere. It really depends on that person and their work with their psychiatrist and different things in order to figure out how long somebody may need to stay. But it is very similar. There's groups that are run during the day that you can attend. And there's some really cool groups. There's really cool groups at the CRU. There's really nice groups. They do a really good variety of things, anywhere from music to animals to all kinds of different types of therapies to try to help somebody increase the amount of coping skills that they have. You do work with not only going to the groups, but you would see a counselor, and then you would have access to see a psychiatrist as well. On inpatient units, it is a rule you need to be able to see that psychiatrist within 24 hours. So you will see them fairly quickly. And that's where you would come up with your treatment plan, maybe adjust some medications, maybe get started on medications. They would really work with you to figure out what's in your best interest from there. So that's a quick version of maybe the differences between the CRU and then a little bit of what they have on the unit.
Great, thank you. So yeah, we've kind of gone from the least restrictive to the most restrictive. And actually none of them is actually a wrong place to end up or to start out, I guess. If somebody had gone to the hospital just because that's where they went, or they called 911 and police came out or something like that, you're going to get to the right, service that you need at the right, hopefully at the right level. So I kind of want to wrap that up because I think we're going to go around real quick here and have time still for any questions that might have come from the viewers. So I'm just going to go around. There's anything real quick you want to say about your agency or how to contact you if somebody wants more information? I know we have in that side panel there some handouts for people that has tons of really good information. And for the people who are watching this after it being live, it will be posted on the county website under the Behavioral Health Coordinating Council forum. So Kevin Richardson, I'll let you go first.
All right, so the best way to reach and the easiest way to reach PATH, we are 24/7, 365. So dial 211. That's the easiest way to reach us. We do have a full 10-digit number, sometimes toll-free numbers and whatnot. So 309-827-4005 is our local number. If you're within our service area for the National Suicide Prevention Lifeline, that's 800-273-TALK. And currently we provide texting services during business hours as well. That ding that you probably just heard, that was actually a text coming in. That was really strange, the timing of that. So the texting that you do is you text your zip code. So if you're in Bloomington, it would just be text 61701 in the message to 898-211. And that would come into, if you're in our service area, and it would ding like that. And if we have staff available, they get to that as quickly as they can. That's the best way to reach us. And I'd encourage you, you know, if you are concerned for someone, or if you are struggling yourself, I mean, don't hesitate. We're all here to help you. And we know it's scary too. There's a lot of reasons that it is scary. One of the biggest reasons is just the confusion about what happens. And hopefully we help clear that up a little bit. But we're not here to judge you. We're here to help you. And, you know, all of them are shaking their heads. I mean, that's what we're here for. So call 211, call the crisis team, go to the triage center. I mean, we're all going to get you to the right spot.
Megan?
Nice job, Kevin. You took my line. Oh, I would say the same thing. You know, I think for all of us, crisis is kind of what we enjoy doing. And we enjoy being able to help somebody who's just maybe not, they're in a place they didn't think they were going to be, possibly, or just, you know, in a spot where you didn't realize it had gotten to that point, or maybe you just have questions. And this is what we like to do, try to help, you know, educate. And that's why we really liked that no wrong door approach. You know, if you call PATH, they're going to try to figure out if that's the right level of care. If not, you know, pass it on to another entity. And in between all of us, really, you know, I think the big thing is people sometimes just don't know where to reach out to. And you know, being able to provide information like this, I think, is so important, because we have a county that has a lot of really great resources in it, and we want people to, you know that they're not alone, and know that you can reach out to those. So for us with mobile crisis, we're kind of in between everything. You know, I would say PATH is a great way to get a hold of us. You know, calling 211, they'll send people our direction. But we also, you know, if it gets to a different level of care, they know how to get a hold of us as well. We're 24/7 as well, so we're always here, and we're wanting to be able to, you know, help in any way we can.
Thanks. And I'm also going to give a plug for Megan. Megan is one of our mental health first aid trainers, and Center for Human Services has several people that are trainers there. Go out into community. There's youth mental health first aid. There's a mental health first aid for adults. There's mental health aid for older people. And I think in the side panel there's handout about that. And one of the things that mental health first aid can do is to help people understand when they see someone that may be going into crisis, so that they can then reach out and help that person with the earlier intervention before it gets to the point where you want to have somebody hospitalized. So I think that mental health first aid can help every resident if they take that and see some signs. So then next would be Lucas.
All right, thank you. I'm going to piggyback off of what everyone else has already said. You know, I think we're all here, you know, because we enjoy helping the community. We really are trying to make sure the quality of life for everybody in our community is much better. I think for SAS, I think it's important to recognize that we can see all of the kids, all of those individuals that qualify for SAS in any location. Kind of the same idea of no wrong door. You can have a crisis at home and not have to take your child to the hospital. We can see you at home. We can see you at school. We can meet you in a park. We can meet you at the store. Wherever you are is where we want to meet you. So that way we are least restrictive. We are in the most comfortable place to have those conversations, those very difficult conversations. And I think it's important to know how to reach cares too, because we may not always be able to, you know, or you know, just have that number handy. 211 is obviously a good number. They can get you to cares. through PATH, but then you can also call the hotline directly. It's a good number to just have saved in your cell phone. That number is 1-800-345-9049. And that's the direct line to CARES, who will then dispatch the staff worker on call to come to you wherever you are. So.
And just to remind people that that's for Medicaid, state insurance.
Correct.
Whereas
under the age of 21. Correct. Yep.
Right, under 21. Whereas Center for Human Services on their mobile crisis, if they happen to get a call and they would find out that that person is then, that child is eligible for SAS, then they then pass that off to you. So this is how we make sure that everybody gets to the place they need to be.
Yep. No wrong door.
No wrong door. So Kevin McCall.
Yeah, so in order to access triage services, we're obviously a physical location only. So you would come to us at 200 West Front Street, also known as the Health Department building. We're centrally located in downtown Bloomington. But in addition to that, I also want to link in the chat here our website where you can actually get kind of live directions through Google Map, no matter where you're at, so that you can find our location. As far as the health department, you come in through the south entrance and there is a big blue door right when you walk in. You ring the doorbell to that door and our visitors aide will greet you, and we are there and ready to go to help you. If you have individual questions for me, similar to our other panel yesterday, I'd like to provide my email, which I'll also put in the chat here if anyone participating today has questions specifically for me about the resources that Triage offers.
Thanks. Deetra?
Hi, so similar to the Triage Center, we are that brick and mortar location at 1001 Martin Luther King Drive, and that is off of Market Street on the west side of Bloomington. If you cross over 55, you've gone too far west. So Martin Luther King is right there by the Culvers and the Popeyes. We kind of give that direction. We are very grateful to the rest of the agencies reflected on this panel from the perspective that many of our referrals come from one of the, well, typically not from SAS given our age, unless it's 18 to 21-year-olds. But many of our referrals come from one of the other three entities. And so we would encourage the use of the numbers provided for, or, an access points described before, or someone can call 309-827-6026, or they can visit the Chestnut website at www.chestnut.org.
Great, thanks. And I'd like to thank our panelists for being here today, and hopefully we've just demystified what happens when someone is in crisis. I have sure learned a lot because I didn't know any of this information. And that to know that there is no wrong door. We're going to get you help. So with that, I would like to know if we have any questions from our viewers today.
Yeah, we do. We actually have a couple of questions here, or at least one question. But first, I would like to let everyone know if you have questions, now would be the time to enter them to the question box. Additionally, I'm going to go ahead and put two more links into the chat. The first one is our landing page for registration for the Virtual Behavioral Health Forum for this year. The second one is a link to the McLean County Behavioral Health YouTube page, which will have not only this presentation and the two from earlier this week, but all of our presentations, over 20 from last year's and kind of this year's Behavioral Health Forum, because it extended over from 2020 to 2021. So those are available for you in the sidebar. The one question that we do have here is the best way to refer individuals through 211, or does each entity have referral forms? What age groups does each entity primarily work with? So I'll answer for myself first, and that the Triage Center works only with individuals that are 18 or older.
I guess
I would echo that that's the same for Chestnut on our crisis residential unit.
And mobile crisis does any ages. And Lucas is youth under the age of 21. And Kevin answers for everybody. So I hope that answered that question on that. So Yeah, just the bricks and mortar are pretty much the 18 and over type of location. So anything else, Kevin?
The only other question on here isn't a question. Miss Sonia Reese just wanted to say thank you very much for moderating this event, and thanks for all of us for taking part in it, and that it was very well done, and I have to concur with that. Thank you everyone for participating. This was really a great experience, and thank you, Susan.
Okay, thank you everyone, and have a good rest of your day.